What is standard is, in recent guidelines from the International Society of Lung Cancer, Study of Lung Cancer, ISLAC has recently published a standard, and so we want to be up to make sure we're doing everything according to the standards, which is EGFR mutations, and we pretty much look at all of the cytoplasmic domain of the sequence for the whole cytoplasmic domain in order to catch every possible mutation that's there. And then we also do ALK and ROS. And then, but our panel, that's a 50-gene panel that we routinely do, does more than that. It does lots of other things like MET and ERBB2 and RET and BRAF. So there's a number of different genes that are done right away when the patient comes in, basically on every patient. And that's kind of the guideline. We're meeting the guideline, and we're kind of exceeding a little bit by doing all these other genes. And then we also do PD-L1. That's part of the guideline as well, to do PD-L1 on every patient that comes in. So that's kind of the starting point. The starting point is changing. In fact, even how we report out the starting point is going to change after this meeting. Roy and I are going to have to chat because we just heard yesterday in the plenary about changing the cut point. So we're going to have to change our report. And so what we have in our panel that we do for every patient is pretty fluid and can respond to new developments as the field develops in immunotherapy.
Right, they put the 20% cut point in now. And
but we don't need it. We're just going to use the 1% cut point is look like as long as you're greater than 1%, then we'll move forward with that drug. So
right.
We'll have to change our report because our report as it's written now says positive and negative, and now that what used to be negative is going to become positive. So MSI was really interesting because there was just one of the first pan-histology approvals. That is, if you have mismatch repair or microsatellite instability, MSI, then you could get a drug independent of whether it was prostate cancer or lung cancer or pancreas or whatever it was. So now, all of a sudden, we have requests for MSI, but it's not until stage 4. It's not until high-grade cancers. So we don't routinely test MSI on anything except colon cancer when it comes in. But now what we're finding is that we're getting requests for MSI or MMR on many different cancer types. And that's actually, the pathologists are getting together. We have a meeting next week to decide, how we're going to manage the requests that we're getting from all over the place. Instead of just one tumor type, anybody who has MSI or MMR should be given this drug. And so we need to broaden our testing. TMB is a different story. TMB is still experimental. And there's been a lot of hype around TMB, and so there are people out there in the oncology world that think TMB is ready to go. It's not. It's been shown in a number of research studies to be very promising. And perhaps the most exciting thing about TMB is it's complementary to the PD-L1 test. So we can see that once TMB is standardized, and we can provide it as a test that means the same thing at Yale as it does at Memorial, as it does at Brigham, as it does at Quest or NeoGenomics, who does most of the rest of the world. Those tests have to be rigorous and standardized at all those different sites. That's in the process now. They're working on that. And so when we see the standardization studies come out, as we did a couple years ago for PD-L1, then the PD-L1 saw broad adoption after we understood the standardization. I think the same thing's going to happen with TMB. We'll see the standardization, and then we'll see adoption depending on the value of the test. Right now, the value of the test has only been shown in a couple of trials, and it's not very sensitive and specific, but it's about the same as PD-L1, but the unique thing is it's different. So maybe we'll do both tests in order to maximize the number of patients we can put on the drugs.
Right. I think with the TMB, it's becoming more interesting by the day. The fact that patients who are PD-L1 negative or 0 can still have TMB high, and it does look like the PFS and the response rates to combinations of drugs such as PD-1, CTLA-4 inhibitors, it looks good. We're still waiting for some more maturation of those data and survival data, but that would be, if we saw that, I'd have to give David a call and say we have to do that, and then we have to figure that out.
We figure out how we're going to do TMB, but I don't want to bring up a TMB test unless I know that the TMB test that I do at Yale is the same as the one that they do in other places. And right now, we're just not ready to do that.
There is a national effort now to standardize TMB. The nice thing is you can start with in silico data, just share data sets and let the different companies use their informatic algorithms. See, TMB is tricky because what do you call a mutation or not, and how many genes do you test? How does it correlate? But then there are so many other things that are going to be coming to play, and we talk about this all the time, David and I, and we need to think about how can we start to incorporate this into our early trials. As I see immune therapy evolving, it's clear it's going to require personalization. It's been 20 years since I sat at ASCO and presented data on EGFR inhibitors. It was at least another 6 or 7 years before the mutations were identified and the field really became personalized. It's going to happen faster with immunotherapy because all the tools are there. We're getting tissue. Pathologists are working more closely with oncologists. However, it's more complicated because now we have the tumor and the microenvironment. But I would predict that we're now going to have to personalize immunotherapy. As good as the data are in lung cancer, and they're historic, we're still seeing most patients with lung cancer die of that disease. It's really still only 1 to 2 out of 10 patients, those patients who have whatever markers we need to identify, that live at 5 years or 10 years with metastatic disease. So we're going to have to continue to search, and that will go beyond TMB and PD-L1. That's going to include looking at the tumor microenvironment. That's going to include sequencing RNA, looking at different transcriptional profiles and signatures, many things that we haven't even thought of yet. And then, of course, there are going to be targets and platforms that don't even involve PD-1, PD-L1. It's natural for oncologists. I was brought up to combine things together, and we do that. But maybe we need to look at other platforms. One of the things we've done, actually very helpful, when I first met David and we started to work on our SPORE grant, he worked with Liping Chen and some of his fellows, and they looked at 450 samples from the archives at Yale University, lung samples, even before PD-1, PD-L1, just at lung tumors we had. And they stained for 2 very simple things, PD-L1 and also for TIL, for tumor-infiltrating lymphocytes. And actually that dichotomized that into 4 groups, either PD-L1 positive or negative, or TIL positive or negative. And actually I was very impressed by those data, David, that 57% of the patients didn't have TIL, didn't have inflammation, didn't have in their tumor. So those are patients that you can block PD-1, PD-L1 all you want. It's not going to do anything. So there you go. Then there was another group, about 25% or so, that didn't stain for PD-L1. And these are big tissue sections, so it's not the small biopsies. So then you have to ask, something else must be in play. And that's why we're continuing to look for new things. Would you agree?
Yeah, I completely agree that it's not just about PD-L1 and TMB, that what we're going to see, because that's 20-25% of the patients are falling in that group. But we have to keep your eye on phase 1 trials and the pipeline, and I think there will be other PD-L1-like drugs that are completely different than PD-L1 that we see over the next few years. And then when we have more than one drug, then we have to have tests that correspond to that. Now, the inflammation, the tumor-infiltrating lymphocytes that we just spoke of, I think we may be a test that works across different drugs, because that's really the status of the patient. It's almost like, germline DNA. It's got to do with the status of the patient as opposed to the status of the tumor. And so I think I have a pretty high degree of certainty that we're going to be assessing that very soon. We actually have assays ready to go in melanoma. We're going to start doing quantitative assessment of some lymphocytes, and we'll move these to lung cancer or other tumors as they're needed. But I think the key thing is that this is about the patient status, not about the tumor status. But it tells you whether the patient's likely to be a responder or not, or whether they should be triaged to something else. And as we increase the number of drugs, we'll see more and more of these types of diagnostic tests.